Hi, hello, I'm Fiona, and I'm one of the MS research nurses in Belfast. I'm very fortunate to work with a great team, and over the years it has grown. We have 4 consultant neurologists, all who have specialist interest in MS. We have 2 clinical fellows in MS, and then there's myself and Loretta. I am the original MS research nurse, so I was the first nurse appointed into the role back in 2020. So I'm not going to go into studies, but just to briefly mention those that we are working on in Belfast. We have a number of observational studies, and also we have clinical trials which are based. Our focus has always been progressive MS, because that's the cohort of patients that aren't, a lot of them aren't eligible for the disease-modifying therapies that are available. Chariot MS is closed to recruitment. Octopus is open, and we are actively recruiting, and you'll hear a lot more about that later on. So just to sort of focus our minds, research does not just happen. There's lots of processes involved, from identifying the initial problem, reviewing literature, setting research questions, choosing study design, deciding on the sample design, collecting data, processing and analysing data, and then writing the report. I want to jump in to focus on point 6, collecting data, and that's where I come in. So, as a research nurse, what are our roles and responsibilities? Pre-study, there is so much work involved before the green light for actually starting to collect data. We need to be trained in the relevant study. Each and every person working on the trial needs to have good clinical practice training, and that's something that has to be renewed every couple of years. Whenever I send that email around to say that your GCP has expired, you can hear the groans in the background. And just for anybody out there, if you have done it once, you do the long training. If you need to do a refresher, there is a refresher, so it doesn't take as long. Don't be like me and do the whole thing over again. You learn by your mistakes. There is a lot of submission of documents to the R&D department, and I don't know about other centres, but ours are notorious for not replying, so you don't know what's happening. You send things off and you just hope that somebody on the other end has received it. In the meantime, study sponsors are contacting you, wondering what's happening, and then you have to write a nice wee polite email, could you please update me, as the sponsors are requesting information. There's a lot of work in the background localising paperwork for use in the clinical setting, and then we start to think about actually compiling a list of interested participants. Our consultants are very good at writing letters at clinic, and we're now electronic. We're on Epic, which you get the electronic referrals in with names, but we compile lists of patients who are interested in future trials. When the green light eventually appears, there's a lot more to do. So our work doubles, trebles, quadruples after that. All of those pre-screen, all those participants who have registered their interest have to be pre-screened. Now, the Octopus has been great because there is a portal for participants to go themselves to register their interest, and then that is sent through to us in Belfast. So for Octopus, there is a whole list of patients sitting on a portal for us, but we still have to go in and pre-screen them. There was one lady the other day who I contacted, and after doing the initial couple of questions and introduced myself and explaining the trial, it turned out actually she didn't have a confirmed diagnosis of MS, and my heart sank, because it's so disappointing whenever you have to turn somebody down. So there's lots done in the background before even that face-to-face visit is booked. We then have to check that the research team are available. Now, our consultants have the teeniest little window for doing research in their working week, and you have everything all arranged, and then suddenly there's a last minute meeting and everything has to be cancelled, and you could cry. But we do our best to try and work around everybody and schedule our visits. We have to book clinical rooms, and this is actually a picture of we are fortunate to be able to use the Queen's NICRF, the clinical research facility, and it's based in the main tower block in Belfast City Hospital. So our main neurology clinics are based there. But we still have to go about booking rooms. We have to liaise with pharmacy, MRI staff, ensure that we're actually using the most up-to-date protocols. Protocols can change numerous times throughout a study, so making sure that we're using updated versions, and to make sure that all our staff are trained and that the training log has been completed as well. Data collection, recording and uploading of information is probably the easiest bit of our job and the most enjoyable. Safety monitoring and reporting of AEs. Over this last few years we have got a lot better, and if anything we're probably over-reporting of AEs, but at the other end of the scale, whenever monitors come, the information's there and we're not going looking for it. We are the participant advocate and we're their support. Loretta and I have our own telephone numbers, and constantly we're getting messages, voicemails or messages through from participants with small queries. But that's our role. We're there to support them. We're there to educate others, and we are involved in promotion and recruitment drives. Now, we haven't yet got the big touring bus for Northern Ireland, but we have done a few tours of different counties over to the west, which is Fermanagh, which is about over 2 hours from Belfast, and we've been down to County Down to speak at local MS Society events, and just telling them what we're doing, and hopefully get a bit of interest sparked for more participants. We are the communicator of the group. We're communicating constantly with the investigators, the sponsors and other healthcare professionals. Preparation of paperwork for visits, that probably takes up a lot of our time, but if you have all your paperwork prepared, your day runs quite smoothly. We also have to think about booking transport for bloods. Some of our bloods go over to London and some are sent to Cardiff. We order supplies and then prepare for sponsor site visits and responding to database queries. Depending on the size of the study and how many participants you have, those queries can be quite hefty. Octopus, we have a large number involved, so the queries are, they're not, they're straightforward to deal with, but it's just time consuming, and it can be on a daily basis. So this is just some of our outcome measures. So we have the time to walk, Sloan, the single digit modality test, which was mentioned earlier, and the 9-hole peg test. So as nurses, we would take on the role of performing these. Now, post-study then, our job's not finished. We have to submit final documents required to close the site. We have to think about archiving our study documents, and then we have to communicate the outcome of the study to participants, and also tell them what trial arm they're in. Now, one benefit, or well, one unique feature to Loretta and I we are both MS nurses in our past lives. So we both started out in neurology, and then I went into MS research, or MS nursing, and then the MS research post came up. That was in 2020, and it was for 2 years. I think we're in 2025, and I think if I said I was leaving, I might get hounded. But what's the benefits of having an MS nurse? So Dr. McDonald was very much, he wanted MS nurses doing research, not just research nurses involved in MS research. So I do think we have some key benefits. We have the clinical expertise and clinical skills. We have knowledge about, how our patients function, and are mindful of little things like time of day, or if you go to get them a drink, not to be getting them a plastic cup that'll fold in on them, to make sure there's something firm that they can grip. There's wee things that we have picked up along the years. We're very much patient-centred, and we are comfortable working with different levels of disabilities. We're also very good at hoisting. The Sarah Steady, I don't know what it's called down here, but we're good at our manual handling skills. Also, we have already that established working relationship with the consultants. So if I need to tell them off, I do, because I can. And sometimes they do need a wee reining in. We also understand treatment impacts. So a lot of the time, especially the secondary progressive, siponimod is now an option. So having an understanding of those treatments, and they're maybe now eligible for siponimod, so being able to actually have that conversation with them is beneficial. And then we're dual rolled. We can still make referrals if need be, physio, continence advisors. We have a new service in the Belfast Trust for the functional electrical stimulator, so making referrals to them as well. So what are our challenges? So we're a small team, we wear many hats. We had, at one stage there we had 3 clinical trials running, but MS Stat 2 is now finished, so we were juggling multiple trials at once. Monitoring visits require preparation and are very time consuming. Scheduling appointments and consultant availability, I've already mentioned that can be very challenging. Our role is not viewed as important to those outside of the team. During COVID, I was actually redeployed 3 times because research wasn't deemed as important. Limited career progression, so just at the moment I moved side roads rather than progressing up the ladder, but I think too, job satisfaction is a big thing, so I'm happy in my role. I'm not worrying about money at this point in time. Job security, so the post is funded. What happens if that funding runs out? One good thing is we have generated money through doing our research, so there's a wee bit going back into the pot, so we are sort of paying for ourselves. Difficult conversations, so letting people down, telling them they're not eligible at this stage, that can be really difficult. Also having that conversation about what type of MS they have can be difficult, because some people have never had that conversation from relapse and remitting to moving on to secondary progressive. Disappointment, I've already mentioned, and then seeing participants deteriorate, especially if the trial is over a period of years. You know what they were like at the start, and that can be difficult, especially whenever you've developed a strong bond with them. Then just research nursing. My views have changed on research by doing this role. In university, it was quite a a long day sitting in the research lectures, but it's totally different in practice. I love being out. I love all the clinical end of things, and one good thing is we have time for our participants. I am quite organised, so I like that wee bit of end of the role, and communication skills, working independently. So we have a nice mix of working together and working independently. Variety of the daily role: clinical data management, and regular hours. We also have opportunities to collaborate with Queen's, and that's why I'm standing here now, because we've made bonds. But prior to this, I didn't actually know what went on in Queen's, and they're only the building over the road. Building long-term relationships with participants. Some of our participants have actually followed us on and from one trial into now Octopus, and it is exciting and rewarding, and our work could potentially advance the lives of people living with MS in the future. Key just take-home points: if anybody's setting up a service and thinking about their research nurse, get somebody that's organised, good communicator, background knowledge in MS would be ideal. Empathetic, works well in a team and is reliable. And if you get a really good nurse, she'll bring you biscuits and everybody's happy. Thank you.